In Lesson 4, we will finish our discussion of cardiovascular diagnostic tests and procedures. Topics will include exercise testing and cardiac catheterization. Exercise testing may be used in the diagnosis and management of patients with CAD. These tests gradually increase the body's oxygen demand and then evaluate the body's response to this increased demand. Exercise testing may include walking up and down steps, exercising on a stationary bike, or using arm or wheelchair ergometry. Indications for testing may include evaluation of chest pain, atypical chest pain, determination of prognosis and severity of CAD, evaluation of the effects of medical or surgical intervention, evaluation of arrhythmias, hypertension with activity, assessment of functional capacity, or in developing an exercise plan or lifestyle change to reduce the risk of developing CAD. Low-level exercise testing may be used on post-MI or CABG patients, or may be used to identify high-risk patients. Contraindications for low-level exercise testing include unstable angina or angina at rest, severe heart failure, serious arrhythmias at rest, second or third degree heart blocks, disabling musculoskeletal abnormalities, valvular heart disease, blood pressure greater than 180/105, and lack of patient consent. Pharmacologic stress testing may be used in patients who cannot perform upright exercise due to disease severity or heart failure, musculoskeletal disability, neuromuscular insult such as a CVA, or an individual unable to obtain a targeted heart rate due to beta blocker or negative chronotropic agents. Absolute contraindications to pharmacological stress testing with adenosine are patients with active bronchospasm or patients with reactive airway disease and patients with more than first-degree heart block. Contraindications for exercise testing include recent myocardial infarction, acute pericarditis or myocarditis, resting or unstable angina, serious arrhythmias, congestive heart failure, or any acute illness. Clinicians may not want to perform the test on patients with aortic stenosis, left main coronary artery disease, severe hypertension, or severe ST segment depression on resting ECG, or compensated heart failure. Equipment used in exercise testing include ECG monitoring, blood pressure and heart rate monitoring, patient-reported symptoms, and heart and lung sounds. The value of maximal exercise testing includes its use as a non-invasive screening tool for detection of CAD. It has a greater sensitivity and specificity in males over age 40 years than in females, as females tend to have a greater false negative result. ST segment depression as a result of ischemia is associated with more severe CAD. Exercise testing with ventilatory gas analysis using a metabolic cart can provide greater information regarding ventilatory, cardiac, or metabolic limitations of the patient. In this test, a patient is attached to a system that automatically samples expired air continuously, a system that measures volume of expired air, a system with oxygen provided electronically, and CO2 analyzers that measure the concentration of gases that are expired. The computer is programmed to measure oxygen consumption, caloric expenditure, and CO2 production during rest and during activity. It is often used to differentiate the causes of dyspnea, with dyspnea caused by underlying pulmonary disease showing rapid, shallow breathing with reduction in ventilation and tidal volume, with decreased maximum oxygen consumption and decreased volume of CO2 production. Dyspnea secondary to heart failure shows a lower than normal maximal ventilation and lower than normal maximal CO2 production. These tests often follow either a standard or pharmacological stress test to further assess myocardial oxygen supply and demand and assess coronary perfusion. Either thallium-201 or systemimbi is injected IV and then scanned, and areas without thallium or systemimbi are considered cold spots without perfusion. With thallium, if the area remains cold 4 hours later, it is considered irreversibly damaged. If it improves, the area is considered ischemic and may improve with revascularization interventions. Systemimbi, or MIBI as it is sometimes called, is superior in that it remains stable longer, so the test can be scanned hours later. It is not retained, however, in acute or chronic MIs. As mentioned before, pharmacological stress testing may be used when patients can't perform standard exercise testing. It is achieved by injecting either adenosine or diprodamol, prastantine, dobutamine, and most recently, regadenoson or Lexiscan. Each of these agents mimics the effects of exercise and therefore can be used to assess myocardial work. If patients are able, adenosine or dipritamol may be used while walking the patient with low-level treadmill exercise, which minimizes some of the side effects of these medications, such as flushing, nausea, and headache. Coronary artery spasms have been shown to play a role in ischemic heart disease. To demonstrate this coronary artery spasm, patients may be given incremental doses of ergonovin, much the same as methacholine is given in incremental doses to reduce a bronchospasm to diagnose asthma. As spasms occur, then medications can be given to reduce or prevent this coronary artery spasm. Heart rate variability tests can be used to assess the risk of sudden cardiac death. In this test, the patient takes 6 deep respirations over a 1-minute period. Heart rate variability of less than 10 beats per minute is indicative of increased risk. Cardiac catherization, which includes coronary angiography and ventriculography, is an invasive procedure indicated for cardiac arrest or ventricular fibrillation, pulmonary edema, intolerance or noncompliance with medications for angina, significant decrease in exercise tolerance, and as a job mandate, as seen with pilots or heavy machine operators. Other indications include progressive decline of systolic blood pressure to less than 100 milliliters of mercury during exercise, left ventricular ejection fraction less than 35%, VTAC with exercise and symptoms of hypoperfusion during exercise, such as pallor, mental confusion, or profuse sweating. Catheterizations are performed in a cath lab and entail inserting a catheter into either brachial or femoral arteries and threading the catheter under fluoroscopy to the chambers of the heart. Pressures are measured in the chambers across the valves, and cardiac output is also measured. Then a contrast medium is injected into the chambers and orifices of the coronary arteries and followed and filmed to evaluate the integrity of the arteries in the myocardium. The cardiologist then interprets the results and assesses ventricular function and the severity of coronary artery stenosis. It is a better predictor of CAD than exercise testing, but is an invasive procedure with sometimes life-threatening adverse events.